Hi, friend.
Hey.
I'm able to, I think I can show you how to turn off the auto Teams thing if you're going through Outlook.
I know, I do it all the time. I unclick
Oh.
it. It just re-clicks it. It's not like I don't know how to do it. It's just as soon as I
Dog.
start like another email, it re-clicks it.
Oh, even if you tell, like, even if you program
The
it in,
original one
like,
always has it unclicked. Like I always unclick it and
but there's
say,
a way to tell it, like, don't do this no more.
oh, well, I mean, each time I just tell it like,
Okay,
and then once I restart another communication, it makes it.
got it. Dear, dear. Um, oh, how you
Is
doing?
Mary on vacation? Because I've been emailing her about stuff and she hasn't emailed me back. She out?
She is not out.
Oh,
Do you
oh,
want me
she's
to,
busy.
do you want me to be like, hey?
No, that's fine. I just had a question. George already consulted. It was a weird Australia case.
Okay.
And it might like it's a young dog with abnormal GBM and like a young female dog and I was like, "Oh, could this be like an output carrier?" So I wanted her
Mm-hmm.
opinion. But
Is that the one that you said you consult or that you
yeah.
messaged to the teams? I don't know that she like ever answers.
No, I emailed her directly originally.
Sorry. This is recording.
Yeah,
Nobody
I know.
listens to this.
I'm not saying anything bad. I'm just saying I couldn't get a hold of her.
Mm.
Um, okay. I will look at this and I do know that Jenna said that she would send her intern to talk about the update for
Oh,
Tiger
good.
Lily.
Okay. Yeah, I would like to know what's going on.
And it might just be the us three. And then we can just, if Dr. Fitzgerald is okay with us just canceling rounds, that might be fine.
We can just be like, hey, kittens, let's go.
I'm dialyzing.
So do you have multiple people there or
No, Steph, JD, and Ray, I think are running around like with appointments, so I'm
got
with
it?
Rory.
Oh, more people are joining right on time. Okay. Yeah, do you guys have a new trainee? Who I just got a biopsy from you guys from Dr. Flassman.
Oh, it's so funny because it's one of our surgeons. It's Glassman. We're
Oh,
like,
see, is it
because I was
Matt
like, maybe
Glassman?
there's, yeah. I was like,
Oh,
is
I
there a
know him. I
Flassman?
was like, that's weird. I know somebody whose name is like one letter off of this. Okay. Well, they
Yeah,
wrote Flassman on the form. Okay, I will change
that's
it.
funny.
I was like, I think he was a year above me in vet school or something. Um, okay, we at least have people here now, and it is recording. Okay, as we are letting or people are joining, we'll do a few housekeeping comments and stuff. Um, this is kind of a haphazardly arranged rounds. I was trying to get one group to be able to discuss their case, but I don't think they're ready yet to discuss it. So hopefully we'll be able to discuss it later this year. That was why I wanted to briefly. I didn't want to cancel because I wasn't even able to participate in May, so I'm feeling like I'm having a withdrawal syndrome from rounds. In general, these are very laid back for anybody who is joining and has not attended previously. These are fairly low key. We often try to get a clinician to present the clinical stuff. This current meeting or this current session will mostly be me presenting the clinical information. But we appreciate when clinicians can recommend or suggest cases for discussion. That being said, if a pathologist also wants to discuss a certain type of disease or has an interesting case that they'd like consultation on, this would be a perfect time for that as well. Usually, like I said, we often have a clinician here to present, but having a pathology-driven rounds is also completely acceptable. So if you are a pathologist and you have a weird case and you wanted a consult, this would be a perfect format for it. They are recorded. They are able to be viewed afterwards. These are international. I think one case that we will be discussing at some point this summer is from Australia, so timing would be very difficult for that scenario. And so things like that might have to be recorded so that they can watch later. They are available for that. If you have been getting invites and then randomly lose your invites, and you notice a month goes by and you don't have an invitation in your email, that is an Outlook issue, and it has happened to a lot of people that have been part of this group. Even our own Dr. Hokamp, who is the actual clinician that is located at Texas A&M, has been accidentally kicked off of the Outlook distribution list. We have no idea why this happens. We think it's a goblin in the system. And so if you just notice a month goes by and you haven't got an invitation, please just reach out to me. We will be able to re-add you back to the list. If you are changing locations and your email is changing, again, it's very helpful for you to let us know so that we can make sure that you're on the invite list and we can delete all of the unaffiliated invites that will just get bounced back to us anyway. Currently, the list is quite large, anything we can do to keep it up to date, and this is all just me kind of with my Outlook distribution list capabilities, can be helpful. Um, for today's cases, and honestly,
Real
I'm
quick
not sure.
before you jump in, just another housekeeping thing. Has the Atlas officially moved over?
Yeah, it's on the Texas A&M
It's on the
website.
A&M one now. Okay,
Yeah,
that's
it's
what
still
I
on
thought.
OSU's. I haven't
Okay, so
told
it's
OSU to
both.
delete
All
it.
right.
Yeah.
But if people need it and are Googling it or something, they should be able to find it.
Yes. Do you want to put it on the chat?
I will do that.
Um, yes, the Atlas has moved over entirely to the Texas A&M hosting website. It will eventually go away from OSU. They asked me to tell them when it is okay to delete it, and at this point, I'm so terrified something will go wrong. I haven't told them that yet. But if you ever want the open access Atlas, there have been a few uh, kind of speed bumps or whatever in the road just because we need to make everything accessible. That has been kind of on my to-do list. I do want to add cats to it, and that is in the plan, but we're trying to at least get the accessibility streamlined first before we start going and adding more content. And there is the list for anybody who wants to have that in their information. A lot of trainees actually already use it, so any attendings that are here and may not be familiar with it, your trainees are probably already looking at it. I do see Stephen Rafferty. I hope that that is Dr. Ati's resident for Tiger Lily. Is that correct? I recognize that name. Who's the Texas A&M person who's going to be giving us an update on Tiger Lily? Okay. Anybody? I will double check with Dr. With Jenna to see who she sent. She said she was sending somebody to give us an update on Tiger Lily. And so while I'm doing that, we'll just go ahead and start with the case um, uh, for biopsy. And Hokip, if you can put in the chat that anybody who's there to talk about Tiger Lily, we'll talk about that at the end. So that I guess, although if somebody joins later, they won't see the chat, but hey, we're trying here. Okay. Let's see. So we have a case today that, like I said, is a little bit atypical of how we present things because usually we have a clinician to talk about information. And I thought this might be a good way for us to remind people that we are doing some AKC CHF funded studies of breed-associated nephropathies. We have a couple of them that are funded. One of them is to look at kidney disease in Shetland sheepdogs or Shelties. We have a certain kind of type of disease we're trying to follow and track in the breed. We also have sponsored studies for boxers and that it did get sponsored and then it had stopped and now we kind of have a little bit more of additional way to fund it. So for any of you guys who have emailed us, we have some capability to look at boxer dogs. And I think that is it, unless we still have the greyhounds.
Greyhounds.
We still have the greyhounds. Um, so um
That one seems dead in the water.
Yeah. So if you guys have come across samples from these animals and they're relatively good quality, especially if you're a pathologist and you're looking at this and they're good quality and they have history of kidney disease or they are AKC certified and they have a pedigree, even if they don't have history of kidney disease, it would be good to at least add them to our database for our description. And just reach out to us, and then we could see what type of information we can do, whether it's just looking at the paraffin block that you might already have, or possibly to do additional examination. Haley, you popped up. I'm not sure if you wanted to take over to share screen or not, or if that was just me. Maybe that was just me. Okay.
Oh, whoops. I somehow unmuted myself, but I don't know how, so
Oh,
ignore me.
that's why it's popped up as a glomerulus looking like a gorgeous amyloid. Okay, that's it. Okay, so this is a Sheltie. I am going to show some information really quickly. This was biopsied last year, and I will give you some information about this dog. She is a 1 year old, 3 month, well, she was at the time 1 year, 1 year, 3 month old Sheltie. She was intact, and I know I'm not sharing anything, but I'm going to share it now. Let's see, this is the information right there. And she had polyuria polydipsia. She did have a litter mate and it says litter mate, so I'm assuming it's the exact same litter and not just a sibling from a different litter. But that dog died with end-stage renal disease, and we looked at that one as well. We looked at that earlier in the year, I guess the previous year. This current dog has mild azotemia, isosthenuria, and an abdominal ultrasound showed nodular kidneys that were quite small. She was not proteinuric or hypoammonemic, and she did not have a blood pressure reported. Pop quiz to all of the nephrologists and nephropathologists that have attended before. Out of that information, there is one feature that there are two features of this information that makes me suspicious for kidney disease. And if you guys want to put in the chat what information you are scared of. Actually, no, there's three pieces of information that make me scared of kidney disease. And Dr. Hokamper, can you look at the chat? Oh, wow, there's a lot more people here than I thought. If anybody wants to put in the chat, what's some of the features that we would say, yeah, this dog warrants a kidney biopsy? Everyone? Okay. Oh,
I
Haley jumped
see.
right in there. Awesome. Okay, so most commonly in our experience at the IVRPS, young dogs with isoscenuria that's repeatable, that's usually what we hear about when we get biopsies from this kind of disease process. So there'll be plenty of dogs where the veterinarian is doing the pre-op blood work and UA because they're going to get ready to spay the dog and or neuter the dog. And they um, do the urinalysis and they realize the dog can't concentrate his urine. They repeat again. And so by the time they're ready to actually do the surgery for spay or neuter, they grab kidney at that time. And that's kind of like an anecdotal but very common scenario we find ourselves in. And a lot of those dogs are not yet azotemic. They basically just have an inability to concentrate their urine. They're very rarely proteinuric. Longer term, late term in disease, they might develop proteinuria. But usually early on, it's just the isosthenuria. Sometimes they have normal shaped kidneys. So sometimes the ultrasound looks completely normal. This dog obviously was being followed because we had already evaluated a previous litter mate that had really bad kidney disease by the time he was euthanized. So they were kind of already tracking this litter mate, this fancy dog. And so they were a little more aware of what might be happening. So I will show you the histology in just a moment. Let me get the right slide up. I'm going to show you the H&E. Oh, here it is. Okay. So we ended up getting, I think, a couple almost like punches and a core. And again, we have a mild azotemia. I think the creat was 1.5. We have inability to concentrate, and we have abnormal looking kidneys on ultrasound. And I would look at this punch biopsy here and be very impressed that this dog still only had mild azotemia. I don't want my one. Okay, so this is the a very damaged region of the kidney. And we can go up to this punch here. And again, we have a lot of inflammation, and I'll get to the glomerular features in just a second. But there is a lot of tubular interstitial disease, and so I'm impressed that the dog has a serum creatinine of only 1.5. Now, if we go to the core actually looks a lot better. So we have mild inflammation and mild fibrosis. But I really wanted to use this as a case example of showing like how patchy or multifocal or even regional this type of process can be. There can be entire regions of the kidney that look completely normal, or this doesn't look normal, but it doesn't look scarred and it doesn't look inflamed. And then there will be other regions which are much more severely affected. We prefer at the IVRPS to get samples that are either wedges or punches. Mostly because we think that the clinician is a little bit better able to get more tissue. And so we recommend getting as many glomeruli as possible so that we can get an assessment of how many glomeruli are affected, how many nephrons are affected. And so this clinician was, again, because we already knew had a relative that had disease, we already had clinical information that this was an injured kidney. They were really good about making sure they gave us a good sample. If they had just given us the core, I probably would have been able to reach with the diagnosis, but I wouldn't have had the severity in mind that the punches give to me. Does that make sense to everybody? I can only see Dr. Hokamp's face, so I'm assuming she's kind of putting her head in her hands like she's got a headache or something, but that's
I do
fine.
have a headache, but also just real quick, Jenna just jumped on.
Okay.
She's got her cap on, so I'm presuming she's got to run to something. I don't know if we want to regroup on her thing.
Jetta, do you want to speak about Tiger Lily, or did you have somebody you needed to want us to talk to?
I can speak to Tiger Lily really fast. I hate that you're looking at renal path though, and we're going back to bladders, but
Okay, I will bring up. Okay, so now everybody, this for the first attendees, the people who have literally just signed up after my ACVP lecture, this is how we deal with rounds. We've got clinicians that are here and they're ready to go to surgery, and she hopped on. So we're going to take a break. We're going to come back and reprocess this Shetland sheepdog that's an AKC sponsored study. We're going to quickly go over to a cat that has a urinary bladder biopsy, actually urethra, right?
bladder.
Bladder. Okay.
It is bladder. Yeah.
And do you want to give us a quick update about that?
Previous urethral slash bladder neck biopsies went to cert. So this cat is a 6-year-old female spayed cat, standard cat, who has a 3-year history of urinary incontinence, who had, I scoped her and did a contrast study approximately a month and change ago, and she had pretty much complete obstruction at the bladder neck urethra kind of junction, just proximal to where her UVJs were. And her UVJs.
And that's what this sample is. This is the older one. So yes, I have the other one after you
Okay.
talk.
So the first biopsy was taken cystoscopically with what I belovingly call my 6-cell biopsy, which was, it's done. We actually use the bigopsy device. It was a backloading device, so you can get more than 6 cells at a time. But it's still a cystoscopic biopsy that is challenging sometimes to get really good samples from in comparison to something like surgical. So that's what this was. And so this was a retrograde approach coming from urethral, from urethra to right up to this obstructive tissue, which grossly characterized was this like proliferative tissue. And interestingly, some comments that were made when we discussed that histopath, I had made the comment that there was bands of tissue that did go from one part of the of what I was presuming was urethra at that time, slash, again, where exactly urethra turns into bladder neck, hard to say. But there were bands of tissues that crossed from like side to side. And then I think it was Hattie that had mentioned, she was like, could this be something like an ulcer that healed. And so there was some discussion as far as like maybe, what we grossly sometimes see in characteristically dogs with quote unquote proliferative urethritis with this gross characterization with bands. Could this be something like a healed ulcerative lesion where tissue healed on both sides, and then you had like this kissing lesion where now you have a band across? And I think that was an insightful comment because we could never get a wire across that obstructive lesion. The plan was to try to balloon it. And we were never able to get a wire across. It just kept going up a ureter. So we ended up taking her to surgery. And in surgery, when we opened her abdomen, her bladder wasn't terrifically large, but it was extremely firm and like turgid feeling, but truly, really, really firm. And when we first incised the bladder and suctioned the urine, her bladder pretty much maintained its same shape, even though it no longer had urine in it. And the bladder wall was probably 3 to 4 millimeters wide. It was really, really thickened and extremely firm and very non-compliant. It looked completely abnormal, and there was tons of blood vessels on the surface of the bladder, like tons and tons and tons of vessels that looked really engorged and tortuous that were running all over the surface of the bladder. And we could not, even with surgery, with an antegrade approach, trying to go from bladder down urethra, that tissue was so firm and challenging to work with, we could not get a wire to traverse it. We had this plan of doing like a bladder neck plasty, doing what the surgeons will call a wide U closure in order to, we make a longitudinal incision and then close it horizontally to make that opening larger. The tissue was so thick and firm that we actually initially couldn't close it. It was so, I don't want to use the word fibrotic, but if that will give you some feelings about how it is manipulative, like it doesn't. So we could not get this tissue to close in this way. And grossly, the lumen of the bladder, the mucosa, looked extremely abnormal as well. And so we did a couple of things in order to try to best characterize this histopathologically. So where we made our incision, we took a full thickness in biopsy, like a piece of bladder, where we gave bladder, we just locked off a piece of bladder and put that in formalin. We also took more like punch biopsies and put some of those near that urethral junction. We took some more of those. All of this tissue looked the same though. And then we actually, in order to gain some compliance, we actually denuded a lot of the mucosa and peeled back and separated like mucosa and we tried to get mucosa, submucosa, and we peeled back a lot of these layers, and we actually like took out the majority of her, what we thought was at least visually mucosa, which we'll get to why that is kind of interesting. And we then put a lot of that tissue in for histopath as well. And then we were able to close her horizontally for the most part. There was some tissue that actually wouldn't close, and so we actually just took that off and also submitted that. And then Rachel had reached out to me as far as like what we had done, which I think will become, it's relevant. And I think that's why I love IVRPS, because we had this conversation to better characterize like what was done intraoperatively, because it was really challenging, I think, for the pathologist to figure out what was potentially iatrogenic versus what was CAT. But thankfully, because we have amazing pathologists, I think we sorted that out. So I'm going to go on mute and let other smarter people talk.
I mean, I think there's a lot of tissue here. This is the second sample. You had reached out. I think, is she doing, oh, is she still with us?
Weirdly, yes.
Okay.
So I left a UCath in her for 5 days, I think it was, something like that. And she's doing clinically, knock on wood, well. So she is no longer incontinent. She is urinating normally. She went home. She was
Okay.
dysuric for a couple of days. Not surprising. We did a lot of mean things to her bladder. But is now urinating normally. And the owner said that they actually had forgotten how she used to be, and she is a different cat. And that
Oh,
was
wow.
about a
Okay.
week and a half
That's
ago,
good.
which
I
is
knew I
also
always
great.
get worried about these kinds of things.
Yeah, we told them
Um,
to be very, very cautiously optimistic.
Did
okay.
you did you send her home with like a red rubber sutured in, or she was in hospital with like a Foley?
She was in hospital with a Foley, and then we had considered a red rubber. I was a little bit concerned for a variety of reasons. The cat did have an infection at one point in time, and then actually grew another infection, and I was concerned about treating her and leaving an open-ended catheter in her. We also we wanted to have her in hospital for a couple of days for pain control because she was quite painful post-operatively. Um, and I definitely didn't want an open-ended catheter here. And so we had a Foley, and we also intentionally with the Foley, we did not have the Foley up against her most proliferative area because that was right where her ureters came in. And so we didn't want to obstruct her ureters. So she had only a 5 French Foley. And then we pushed the balloon. We actually placed her Foley intraoperatively after we got wire access, placed it over a wire, and then had the balloon kind of mid bladder, and then closed over Foley, being really careful not to grab Foley with a suture. And then I sutured the Foley. I put not a finger trap and a butterfly tape on the Foley and sutured it to the cat so that we weren't applying pressure and not potentially occluding ureters because that was a big where her obstruction was I mean right at her ureteral openings, and so that was a I looked for like something that could be potentially fenestrated to not obstruct your ureters. I couldn't come up with anything better, so that's what I did out of lack of better ideas. And then she had it, I think it was 5 days. And then we pulled the Foley in hospital and made sure she could pee. We also did POCUS daily to make sure her renal pelvises weren't getting dilated because I was really concerned that if this cat becomes reobstructed, she's going to obstruct her ureters.
Yeah, weren't her ureters fairly almost like caudally located near the neck? Okay.
They were.
I was not at the last set of rounds, so I didn't get to see that amazing image, but I think you took a snapshot with your phone once, of the so I guess uh one thing I would say about this is, especially if you're removing stuff and you're like, hey, I really need to flag that this is the part that came from the urethra and this is the part that came from the urinary bladder, and we've had these kind of conversations before. Most of the people will put either in a cassette the stuff that's urethral and then the bladder in the formalin jar, so at least we can say which is which. Sometimes people will just submit different formalin jars so that way we can keep them separate. For the IVRPS, for lower urinary tract specimens, we will look at different locations specifically at the same fee. So it's not like you're paying for two sites if you do urethra and urinary bladder. Um, anyway, you can flag us about which is which, and we kind of have two different types of tissue here. And so these kind of all get put together on one slide, and you can see there's a long stringy part that's quite hemorrhagic, and the hemorrhage is pretty acute. We're not seeing a lot of hemosiderophages in here trying to clean up. There's still kind of polymerization of fibrin and stuff. So, and it can be hard for us to say this is procedural because they just basically now traumatized the bladder when they went in to get the samples. They had done a biopsy, I think, the week before, kind of at the urethra and neck area. So we've already had procedures into this lower urinary tract, relatively recently. So a lot of it can be what happened a couple days ago, what's been going on for months. But I usually try to look in regions of hemorrhage to see if I have emetorophages, and that will kind of help me say this has been going on for a while. Most of this stringy piece does not have intact urothelium, and it was concerning for ulceration. And I think that you can see this kind of discolored portion on the surface of the sample. And so when I'm looking at ulceration or I'm looking at urinary bladder samples and I'm wondering if they're ulcerated, I like to try to find, can I find any urothelial mucosa? So I will scan the whole section, trying to find a couple islands of urothelial cells. And then another piece of evidence is, do I have fibrin? Do I have a serocellular kind of coagulum on the surface? And if I have that, then I'll think this is real. This isn't something that happened iatrogenically during the procedure. And so this guy definitely has that kind of color change at the surface, to make me think that this is something that happened recently, but it's not an iatrogenic situation. So that's kind of that long stringy piece. There's other pieces out here that do have urothelium. And so again, I'm not entirely sure which area it came from, but we still have hemorrhage, not a lot of hemosiderophages, so possibility that part of this hemorrhage is iatrogenic. We do have intact urothelium. We have kind of this like a little bit of serum that's kind of underneath the regions of the intact urothelium. That's this little kind of hazy pink material. And we have a separate piece that now starts to have that similar type of proliferation that we were seeing in the previous biopsy that I showed, where there's a lot of not neoplastic, sorry, urothelial cells, and they're right along the surface. And cats tend to do this where they'll have that hyperplasia and it'll kind of just be a band along the surface of the sample. And so that's kind of what is going on in this one particular piece. But again, I'm not entirely sure where this is along the length of that area. I think what's kind of hard, and it might imply part of this question of like a lack of compliance or lack of elasticity of the urinary bladder, is that sometimes when I'm looking at a sample and I'm like, okay, I'm trying to identify urothelium, I can see there's fibrous tissue. Is that lamina propria or is that actually smooth muscle yet? And once it gets really pink, it's like, okay, I want to call it smooth muscle because it's really pink, but that's not what this cat's smooth muscle looks like. That cat's smooth muscle looks like this. This is definitively smooth muscle. I can see the linear kind of squiggly nuclei. And I have that kind of color change of the cytoplasm. So I do think that part of your explanation of like lack of dilation of the bladder or compliance of the bladder is that the lamina propria is abnormal. And there's just a lot more matrix there than you would see in a normal lamina propria. Let's see if I can find like what I would think. This would be similar to more normal lamina propria, kind of pale pink vasculature that you can see in it. Yes, there's hypertrophied endothelial cells and we have circulating inflammatory cells, but to me that looks like what the typical color that you should see for lamina propria. And so I'm not sure what to do when I get to that denser peak region. If it's just, is it an abnormality of the matrix? Are there smooth muscle fibers in here that are kind of bundled up and intermixed? And that can be, it's kind of the difficulty with the specimen. But it goes with your description grossly and palpably that it was quite thickened and lost of elasticity. So in the end, I can't tell you exactly what's going on other than we have this ulcerated regions, we have regions with intact urothelium, and we have hyperplastic urothelium on that one piece. But there are areas where we definitely got smooth muscle, and that's what this cat's smooth muscle should look like, where it's very linear and the nuclei fit that appropriately. So I don't think I get to answer your question, but I'm very excited the update that is the cat's doing well. Um, I'm sure, I guess we should look in the literature to see about abnormal compliance and elasticity of the urinary bladder. That's almost like, how old is this cat? Is this cat young?
6.
6? Okay.
Yeah, I
Because
couldn't
it doesn't
find
seem
the
like this would
exact
be a
age.
degenerative thing. This seems like it's just an abnormality. And if it also had kind of ectopic-ish caudally located ureters, then maybe this all is just always been abnormal.
Yeah, I mean, she seemed like she was like a normal cat for 3 years of her life, and then developed lower urinary tract signs, and then developed incontinence
Yeah,
post.
she had had a long term of incontinence. Now I'm remembering that history. Yes.
Yeah, and all of this tissue to Rachel was taken from the bladder side of things. None of it was
Okay.
taken from the urethral side. It was all bladder.
Okay.
Um, but yeah, I had looked into one of my questions that I don't think we can necessarily answer, but I had looked into could like ulcerative cystitis with knowing that there was like seemed like ulcerative type lesions. I looked into ulcerative cystitis, both in cats and in people. There's really not any good any good literature in cats. Sometimes people describe ulcers with FIC, but there's not a lot of
Yeah.
detail with that. In people, it's interesting. There is an ulcerative cystitis that is in the umbrella of interstitial cystitis. But what is particularly interesting to me is when I was looking at treatments for those people, they do respond to immunomodulatory therapies, and cyclosporin, as an example, is utilized commonly. Well, shouldn't say commonly. It's utilized at least in some, and there's been some papers that have looked at that agent specifically. And it's what is interesting is like for women who have cystitis, the response, like sometimes it's really bad, and these people sometimes get cystectomy as a treatment because it's so miserable. And there's this whole syndrome called bladder pain syndrome.
Hmm.
And it sounds awful. And like to the point where people literally get a cystectomy and do like all these urinary diversion procedures. But what's really interesting looking at this is there does seem to be phenotypically a difference between the women, it's primarily women who get ulcers and those who do not. And
Hmm.
and I have to believe it's a different disease process because the people who get ulcers are much more likely, like it's like an 80% response rate to cyclosporin. And the people who do not have an ulcerative phenotype but have
Hmm.
same disease, it's like a 30% response rate. And so like there does seem to be like this very distinctive
Yeah.
difference in how you should treat these people, and which makes you think like, is it a different etiology? I have her immunosuppressed now. Um, and and I think I'm considering like, do I leave her on cyclosporin? I'm not really sure. But she seems this process seems bad. And she's clinically doing okay. And I feel like if this process gets worse, that would be really like, and I've also now spent all these people's money. Um, so I can't do a whole lot more from an interventional standpoint. But I think the other thing is I don't even know what I do. Like if she reobstructs and she obstructs her ureters, I mean, I was looking into like some like pretty crazy stuff. Like, could I reroute her into like her gallbladder? It turns out that's a bad idea in people. It goes really, really badly. So I probably
And
wouldn't
I
do.
would assume being a single common bile duct in a cat to have it.
Yeah, yeah. So I like looked into like all these like really insane things for these people who love this cat. But I think honestly, if she obstructs, she's dead. So at this point, that's where we're at. And so I don't really,
I
I
think
mean,
the ulcerative and how this would heal, and I think the pathologist, I do know there's a few straightforward pathologists on this. Like when I think of an ulcerative lesion, whether it's urinary bladder or intestine or whatever, I would expect a lot more kind of granulation tissue with like capillaries doing the run to the surface and a perpendicular aspect. Now, sometimes when I'm fortunate enough to see that from a cystectomy sample, like a partial cystectomy or like a little bit of a sample that came from a cystotomy, I have full thickness of the urinary bladder, so it's a lot easier for me to orient. Like, hey, this is definitely lamina propria. I can see all the capillaries running to the right location. So this pattern doesn't look like normal granulation tissue to me. It just looks like it's a lot of collagen and maybe it granulated a while ago, and now we're just in the fibrosis part and the lack of the vasculature, which is a possibility as well. But I think from in the pathologists that are on there, if you have a comment about it, but when it's hard when we get cystoscopy samples, and I understand it's so much easier for you guys to provide them, and it's also therapeutic for you guys to do the cystoscopy. But a lot of times we're just trying to figure out how to orient and see where we can find the top and the bottom. And I think this one is hard because a lot of that urothelium is absent. Um, so um, so I think it's interesting. I think you're right. If she does reobstruct, then it's very unfortunate. So hopefully we can keep her urinating as much as possible. And if they decide to euthanize and you can get urinary bladder full thickness wall, that would be helpful for an autopsy specimen for us to look at. Um, I don't know. She's a really good. Um, we have a comment here from staff about doing a sub if they possibility did that. Would be possibility is putting in a sub.
Yeah, the
Um,
problem is where like she's obstructing at where her ureters come out. So like where her UVJ is, that's I think so her whole bladder is affected. I mean, like the whole bladder is abnormal, but I think the reason this cat obstructed was just this proliferative, not proliferative,
it's
but
right
this
there at that neck, yeah.
thicker tissue because the bladder gets narrow. A cat's urethra, I don't know, 8 French, 10 French, something like that. It because of the thickness of the tissue, it just there was now no more space, and so it was obstructed. But the process is everywhere. So even if I subbed her, there wouldn't be she would have like I think if this continues, she's going to obstruct her ureters. So she'll obstruct her ureters, but there won't be like her problem before was that pee couldn't get out of this cat. From her bladder. The reason this cat was incontinent was because she was peeing into her urethra. Like she had so much thickened obstructive type tissue, and it happened to be just proximal to where her ureters came out. That if that process continues, even if we were to sub her, and let's say we put urine now in the bladder, she's not going to get urine from bladder to out of cat. So I'd have to sub
Yeah.
and do a cystostomy too, which sounds miserable. Like I don't,
Um,
that's my problem is I don't have an exit strategy for the urine.
yes. Well, I do think it does underscore. I've had at least probably 5 to 6 cases in the past couple of months, which are cats with dysuria, some type of stranduria, and the clinicians looking into literature saying, I don't know what FIC is supposed to look like. And I say, I don't know either. Like, it isn't well described in the literature. FIC seems to be a very good, okay, yes. Okay, so we have Dr. Specht on there. That's good granulation tissue where you're seeing the capillaries run towards the surface in that chat picture. But yeah, so like I think that whatever has been diagnosed by clinicians as FIC have not always been biopsied, or the biopsies haven't been well scored or well arranged. So I do think it does represent another set of in research that we probably need to engage in among our other many projects is just to have better, like to have that type of categorization, like you were talking about, like these ones are ulcerative, these ones are not, these ones are pure inflammation, these ones are hyperplasia, and better sort those out because I have had multiple clinicians saying, like, I'm wondering if this is an FIC cat, can you prove it on histo? And I'll be like, well, I don't see inflammation, therefore cystitis isn't the right word, but it's really fibrotic. So maybe it's something, maybe it's all that clinician. She does not have a normal urine bladder volume, correct?
Um, I would say it's under what a normal.
Underwhelming.
Well, yeah, so her bladder isn't very stretchy. So her bladder capacity is smaller than I think an average cat. Um,
It's like she has HCM, but of her bladder.
yeah.
Wonder if she has heart problems. We should look at her heart. Maybe this is a systemic type of lack of muscular contraction. Um,
Yeah,
Yes,
her bladder is, yeah, she has diastolic dysfunction
of
of
her
her
bladder.
bladder.
Okay, so I do want to wrap up the kidney case, and I want you guys to be able to get back to your surgery process. Thank you so much for joining in and hopping on at the last minute.
Thank you, sorry.
And we will obviously keep us updated on this cat, since we've had a lot of discussion about it. And anybody who is on the call, we're still going to stay on for kidney, but if anybody's really interested in FIC and further characterizing it and wants to start a project with us, we can collect the cases for you. Okay. Okay, so we are gonna hop over. I'm gonna go back to the kidney. Now, if we remember back to our kidney, we had a cat, we had a dog. It was young. It had a litter mate that had died of end-stage kidney disease, and we had said it was really scarred kidney by the time we looked at it. And the dog had our current patient has isoscenaria, mild azotemia, and abnormal kidney shape on ultrasound. And we looked at the histology, and I already showed you that the histology was kind of multifocal, where we had wedges that were definitively affected, and then we had a core. Oops, what did I just do? Cores that were that was less affected. So now we're looking at the PAS, and I like this stain. I'm keeping time on the clock, so I'm kind of going fast. I apologize, but I like this stain because it's better at showing me where the nuclei are located. I think this is a great example. So we have nuclei in here that are definitely inside a capillary lumen, but we have these nuclei out here, which are definitely in mesangium. Also, when you have segments of scarring of the glomerulus, which is the term glomerulosclerosis, is synonymous with glomerular scarring. And granted, the scarring can happen for multiple different reasons. It doesn't tell you what caused the scarring, but it just tells you the glomerulus itself is starting to scar down. Here we have a segment of glomerulosclerosis. There's no capillary lumens in that anymore. We just have entrapped nuclei. This capillary lumen is patent, but again, it's wrinkled. And so I think the PAS stain is showing us we've kind of got a fairly normal cellularity. It's just that everything is wrinkled and squiggly lines. So that's the PAS that's useful. We can also say that the PAS helps us identify glomeruli that might have been overlooked if we were looking at just the H&E. So this little guy here is definitely a glomerulus. You can even see his Bowman's capsule kind of out here. He probably never developed normally. He probably was always an abnormally shaped glomerulus, maybe an immature glomerulus. But I might have missed this by just looking at the H&E, because everything would be pink. I mean, I can go back and let's compare. Hold on. We'll test my theory out for a second if I can find him again. I think it was maybe, oh, maybe, I don't know. No, I don't even know which one I would have seen. But so I think that the PAS is very helpful when it can show us things that might have been overlooked with an H&E only. But if we do, sorry, I was looking at the wrong wedge. That's my fault. If we go back to the core, now I told you the core looked a lot better, right? So now we're going to look at the glomeruli in the core. Again, it's really good to tell us where the nuclei are located. We have a nucleus here inside of a capillary lumen. We have one nucleus, that's acceptable. We have one nucleus out here, that's acceptable. And we have a nucleus in here that's mesangial. And so when I'm looking at these, I'm kind of doing an overall assessment, but I usually only have, I don't know, 30 glomeruli to look at. So I can spend time with each glomerulus, get to know its vibe, and figure out how I want to diagnose it. So we've got some fairly normal glomeruli in that long core that's much better preserved. And so the other thing in this other core, these guys again, these small little guys here, I will tell you that I called those immature or fetal. This guy's a better fetal one. The fetal ones are really cool because they have the really prominent nuclei on along the surface. I call them podocyte progenitors. I don't know if that's right, but that's what I call them. And then you go up to this guy. This guy has hardly any capillaries, so he never really capillarized, and that's another kind of immature fetal glomerulus. Let's go to the trichrome. Trichrome's great. It's going to show us all this collagen. Look at all this collagen. Collagen for days. And it's cool because we can see here is a collecting duct. All of these are either vessels maybe there's a thin limb in here, but I think most of these are vessels. We have to go from this one all the way to here. We hopscotch all the way to here, and we finally get another collecting duct all the way to here. So there's a lot of extra matrix in between our collecting ducts. And now in this kind of like little punch area, I think they took these little punches from like the indented part, the part that said it was kind of abnormally shaped. So we have lots of extra collagen. And again, kind of almost what we're talking about with the cystitis case, I'm not seeing a lot of inflammation here. I'm just seeing a lot of vessels running kind of the right way, running parallel to one another, which is what vessels should do anyway in this region. But I'm not seeing like huge regions of suppurative inflammation that would show that, hey, this was a pyelonephritis and now we're scarring down. This looks like all this collagen was always there. This has always had collagen there. Um, and we can do the same thing over here in our other wedge. Again, huge regions that are lacking. I don't even see any collecting ducts in here, so we're just like absent of collecting ducts. We go to our better preserved core, and this looks pretty good. We have a little bit of fibrosis. I mean, it's concerning because it's only a year and a half dog, but we have a little bit too much fibrosis. But the rest of the parenchyma seems like it's well preserved, and our glomeruli sometimes have dilated Bowman's capsules, but other times look fairly healthy. And so I pre-limbed this as suspect maldevelopment because we had immature glomeruli, we had fetal glomeruli, we had regions that lacked collecting ducts and for the most part tubules, large regions that had that. And then obviously we have the clinical history that we had as a young dog, we have an abnormally shaped kidney. So that's kind of those features we often see. I can show you the Jones. I don't think it's that, it's fine. Just so you guys can get more familiar with what a Jones should look like. This one's actually even a little bit understained, but you can see that these are capillary walls. Here's a good capillary wall there. And when we want to compare for normal capillary walls is look at this GBM and compare it to the TBM of a normal healthy tubule. So as long as it's thinner than the TBM, then it meets it's a normal capillary wall. So again, we're going to compare all of these and it is still thinner than that normal capillary wall or normal TBM, excuse me. Okay, so we're gonna go. We have 10 minutes left. This is a very haphazard rounds. I apologize, guys. We are better at doing this when it's much better when we don't have to cajole people to present their cases. Just putting that plug out there for the clinicians. Okay, so I know I'm not showing anything right now. I'm trying to get to the EMs. Here I'm not. No, I'm at. Okay, so we did electron microscopy. And like we said, these are, how do I want to say this? These are sponsored by the AKC, and so when we are able to do additional studies for these, and so if you guys have one of these cases come across your desk, most of the time we're actually just looking at urine from these guys and collecting samples for DNA so that we can follow the track of disease through their pedigree. But if we have the possibility of doing tissue analysis, we're going to attempt to do that as well. So I'm just showing you the EMs from the report. I'm going to make it a little bit bigger. Hold on, I want to make this a little bit bigger. Make you bigger. Okay, so these are the EMs. And so we are able to identify glomerular basement membrane. It is the right thickness. Younger dogs have a fairly thin GBM. And it seems to get bigger, thicker as the patient gets older. And we have a podocyte here with our podocyte nucleus. Here's our podocyte cytoplasm. And we have intact foot processes along the capillary wall. We have a few segments like this little segment here, which is effacement of the processes. So there's a little bit of patchy effacement of the podocyte foot processes, but a lot of the times you can still see they're intact. I always kind of not sure how to say the word, but I often think that that there's kind of like a raggedy cytoplasm of the podocyte. You can see like here's a little bleb of cytoplasm and he doesn't seem to really be attached to whatever this nucleus is. So, I mean, I know that's the podocyte nucleus, but I don't really see where his cytoplasm even exists. So you can kind of play the game of like, is this actually podocyte injury or is this kind of a preservation artifact? Is this like a glomerulus that ruptured when the biopsy came through because of iatrogenic core cutting through the biopsy and that made the podocyte explode? And it's kind of about frequency of that. If I see like every single podocyte has a ragged appearance, and I don't even use that word, but that's what my brain goes to, then I get worried that the podocytes have been injured. Again, good GBM, no evidence of electron dense deposits at all. And so I'm not worried about immune complex disease. I'm just seeing a few foci of effacement. Here's a good area of effaced foot processes. Again, here's some ragged, maybe I will start using that word. I've been saying a lot. Some ragged podocyte cytoplasm. Here's our little mitochondria of our podocytes as well. So at least we could say that we know we have, again, the histology appearance of small fetal immature glomeruli, lack of collecting ducts in some regions, non-inflamed fibrosis. The glomeruli that did develop are likely larger than they would have been. And so we again don't have specific cutoffs of how large a glomerulus is allowed to be. It's just kind of our trained eye of, hey, we're used to looking at a glomerulus and it should fit in this field and it's not fitting in the field. So the understandably reasonable theory is that when there are fewer nephrons, because fewer of them developed, the ones that did do their job and correctly developed have to get bigger to filter all the blood of the patient. So there is some degree of hypertrophy of the glomeruli. And when those glomeruli have to get larger, their capillary walls stretch. They don't make new capillaries. They don't make new podocytes. They basically just stretch a little bit. And that stretch overloads the workload of the podocyte. And so that's when they start to lose their amazing cytoarchitecture with those gorgeous foot processes. It's because they're kind of stretched and they're overworked. Now, this will take time to do. This doesn't happen at 6 months of age. This doesn't happen at 3 months of age. It usually happens a little bit later in life. And oftentimes it depends on how much the kidney had to grow or compensate, how much the nephrons had to undergo hypertrophy. If it only had, 10% loss of nephrons or absence of nephrons, that kidney is probably going to be fine. It's the kidneys that lost half of their nephrons or had half of their nephrons not develop appropriately. Those are the ones that are going to show symptoms earlier, and they're going to have the podocyte injury earlier, the compensatory hypertrophy earlier. So the lesions are kind of can be variable. It can be nonspecific if you don't catch the glomeruli that are small and sclerotic and fetal and immature. If you don't catch those on your biopsy, you would just look at regular scar and you wouldn't be really sure what the initial cause was. So again, this is just a public service announcement. If you guys have these patients coming into your clinics, especially if it's a pedigreed Sheltie, or has relations to a pedigree Sheltie, or has relatives that also have kidney disease as well, please contact us because we're kind of behind in enrollment of these cases. And we need to get more urines from them first, and DNA from them first. And then if the owner is willing to do a biopsy, then we would have more tissue for them as well. Dr. Hokamp and Dr. Nabedy, do you have other comments about this study?
Put the link in the chat for the study pages. I don't know if Navity wants to.
Yeah, that's the main thing. To either sign up there or our contact is on the information page regarding it as well.
Yeah. Okay. Any questions from the pathologist? Any questions from the clinicians? Like I said, we have this study, we have the boxer study. So if you have new boxers that are coming through with, and we're specifically trying to look at renal maldevelopment in boxers. So especially if they're a young boxer, we would like to get DNA from them. We're collaborating. That study is a collaboration with Cornell. And so we're trying to help them recruit patients and look at a possible genetic basis between maldevelopment in that breed.
The
And then the last one
requirements,
is-
the requirements for that one is that they do have to have a definitive diagnosis of renal maldevelopment. So it's at least from my understanding with talking with Jacqueline, so it really can't be just the biofluids in those cases.
Yeah, but I think if you had ultrasound evidence of maldevelopment or something like that, or that was a young dog, she probably would at least take the DNA for it. And again, they want mostly AKC certified, correct?
Yeah. Yes.
That
Yes.
agreed.
Yeah, and so far with the Shelties, it's suspected of maldevelopment, but it doesn't need to be confirmed to participate. But it shouldn't be just a proteinuric old Sheltie that's probably not anything related to maldevelopment, at least at this point in time.
Yeah. Okay. Yeah, I hope everything is going forward. We think we have a set of rounds for July already figured out, but we are gonna wait to give that topic in just a couple weeks to make sure that we have confirmation from everybody to participate. Again, for those of you who are the first time attendees, hopefully you realize rounds are kind of fun. They're just like fly by the seat of your pants, see how things are. People please participate and ask questions and have some kind of dialogue so that I don't want it to just be me talking. Okay, any other questions?
Rachel, I was
Um,
just going to say really quick. I have sometimes used the word tattered to describe epithelial cells in histology reports.
oh, I like tattered. Yeah. I
That's an
think I just
option.
need yeah. And you can't really say attenuated because oftentimes we'll talk about like when epithelial
Yeah.
cells are lost, there'll be attenuation of the rest. But
Uh-huh.
yeah, sometimes you just see that cytoplasm, you just see those tiny little fragments, and you're like, was this truly in vivo like this, or is this something that happened during the procedure? And
Mm.
yeah, we need a better word for that. So okay, well, we will reconvene next month. Thank you guys for participating. And hopefully we didn't scare you away. Thanks, guys. Bye.